It's my pleasure to introduce Beth Faiman, who is one of the members of our Nurse Leadership Board. As far as I know, we're the only organization that has such a board, and they're made up of the most amazing nurses from different institutions around this country who have written guidelines that Beth is going to talk to you about. Without the Nurse Leadership Board and their published guidelines, nurses across America and around the world would not really know how to take care of their patients and overcoming the side effects associated with these novel therapies. So what you're going to hear today from Beth is really, really important, and we're so pleased to have her back again.
I would like to thank Susie Novus and Dr. Dury and the IMF. I think, oh, this isn't on. Testing. Are we on? No power. I'm going to use this. I'm going to pretend I'm in a game show. How's that? Yeah. I would like to thank Dr. Dury, and can you hear this? Closer, like this? I have a big mouth. This is usually not a problem, but thank you for having me today and listening to this. You know, I've been taking care of patients with multiple myeloma since the mid-1990s, and I've seen such a change in the landscape. We have so many better drugs, and now we're faced with how do you manage the side effects of these medications? One of the things that in my Nurse Leadership Board that the International Myeloma Foundation sponsors is really focusing on the survivorship aspect. Think of when you were diagnosed, maybe even a few years ago, you were told what? I have 2 or 3 years to live, and that's not the case. And getting the word out there is a challenge. What we're recognizing is that patients are actually experiencing heart problems and lung problems and all of the issues that you would normally experience as you age. And so what we're particularly involved with is the key to prevention, you know, living a healthy lifestyle, getting out there and moving more, exercising, eating healthy. We're also focusing on management of the disease and above all, quality of life. It's one thing to get the disease under control, but then what do? You need to have a good quality of life as well as a quantity of life. So today I'm going to talk about some of the things that we work at the Nurse Leadership Board that's sponsored by the IMF. And one of the things we do is we like to get out there and educate on some of the words that you're going to hear. Now, many of you are very well versed in myeloma, but for some of you that are newer, I'd like to just share some of this. Thank you. Pardon me for a moment. Can you hear me a little better now? No. Move it up. Oh my word, I've never had such technical difficulties. How's that now? Oh, thank God. I thought I'd have to go home a minute. Anyhow, all right. So one of the key words that you're going to hear is anemia. So anemia is defined as low red blood cells. And symptoms of our anemia are being tired, a little bit of short of breath, depending on how bad the anemia is. And what happens? Well, it's twofold. So the red cells are produced in the bone marrow, and myeloma can invade the bone marrow environment. So that crowds out the healthy cells. And this is the same for if you have low platelets sometimes. But anyhow, you can have the fatigue and weakness that we all worry about. A high protein level can be in your blood or your urine, or you might be somebody that's not producing too much protein. The myeloma cells do, though, produce proteins, which can be sticky, and that can make you feel sluggish or tired as well. Other things that you might see with myeloma now, I was commenting to Susie, we've heard a lot about bone damage here, and Zometa and Iridia are 2 great drugs to protect the bones. The key is to protect your bones because steroids can weaken the bone, myeloma can weaken the bone, and it can lead to bone pain, damage or lytic lesions, and collapse of your vertebrae. I heard discussion about kyphoplasties and vertebroplasties to protect and restore the height of the spine. And so those are things that we want to think about not only at diagnosis, but as long as you're living well with myeloma. A high blood calcium can happen as well when the bone is losing calcium and it goes into the bloodstream. And so we see that at diagnosis, but at any time during your treatment, that might be a sign that the myeloma is active. Now, if you're on calcium pills, or certain water pills, sometimes the calcium can be elevated from that. So we'll be checking your calcium levels regularly to look for it. If it's from the myeloma, you can become confused or weak or tired or constipated, and those are things to look at and report to your provider. Reduced immune cell function is really important. Now, years ago, criteria for diagnosis of myeloma include frequent infections. Now we kind of shied away from that. We look for frequent infections, but know that you're more susceptible. Wash your hands with soap and water, avoid people with colds, and look for temperature of 100.4 Fahrenheit and report it immediately. As I mentioned on the previous slide, not the last one, the one before that, we do have goals of treatment, our rapid, effective control of the disease, but once you've got that under control, we need to manage the disease symptoms. We want to improve your survival, and you're going to hear tomorrow about all the exciting things that are going on, all the clinical research that have shown the drugs that we have now and available now can actually make you live longer. And we also want to make your quality of life better while on therapy, and that's what we're here as the Nurse Leadership Board we like to do. So what are the kinds of drugs? The IMiDs are the pills, and they are thalidomide, lenalidomide, and pomalidomide, and those are all by Celgene Company. Those are the ones that are approved by the Food and Drug Administration. The proteasome inhibitors, we have 2 of them now that are approved. I'm just talking about approved ones that you have access to off of a clinical trial. That's bortezomib, or Velcade, and carfilzomib, or Kyprolis. And that's by Millennium Pharmaceuticals and Onyx Pharmaceuticals. Now, those are mostly what we're using, and I don't want to go into detail about all of the many, many drugs. You'll hear about those tomorrow, but we have lots more drugs in development. Pardon me. Conventional therapy, those are your chemos. I heard somebody in the audience was on Cytoxan or cyclophosphamide, and Dr. Dury was talking about the Cybord D. Now, cyclophosphamide and melphalan have been around for years, and those are more of conventional chemotherapies, but we're taking lower doses and combining it with our newer drugs for better responses. A lot of you will have access to clinical trials, which we haven't gotten as far in this year, 2014, without your participation, and so that's really important. Now, some of the other treatment options that you'll have would be radiation. Now, when I started taking care of patients 15, 20 years ago, we didn't have good drugs to treat myeloma, so we gave radiation all the time. Your oncologists and radiation doctors are probably a little bit more careful about how much radiation you give to only identified tumors like plasmacytomas, because we want to spare the bones and bone marrow of too much damage that the radiation can occur. We've talked about stem cell transplant. That's also an option. It's considered standard of care. Some centers believe that as long as you have a pulse, you're a stem cell transplant candidate, but there's a little more that goes into it we'll talk about. And then supportive medications. Again, myeloma treatments destroy the blood cells, and supportive medications help you through that. So that's your bone builders to strengthen your bones, anti-nausea medicines, and such. Now, this is a slide here. Remember I mentioned thalidomide and lenalidomide and pomalidomide. Those are your 3 pills that are used to treat myeloma. And then bortezomib and carfilzomib, those are your injectable proteasome inhibitors that control myeloma. And this is a nice graph that we put together that shows you on the left, these are the side effects that are most common that you would experience when you're on these drugs. And you can see that the check marks are in different areas, so we mix and match drugs, trying not to overlap those side effects. There are a lot of things that can happen if we're not properly managing your side effects. Number 1, you're not going to want to take a drug that gives you side effects that aren't managed. So you have to let your doctor, your nurse, or whoever is taking care of you know about this, because this can have a really big psychological effect. Diarrhea is a very big side effect of long-term lenalidomide or Velcade treatment, and so we really want to make sure that we know if you're having this side effect so we can provide strategies to take care of that. Think about that same diarrhea side effect. It can also cause physiologic impairment. You can lose water, you can become dehydrated, and have electrolytes such as potassium problems. So again, it's really important to report these things. Reduced adherence. I mentioned already before, you're not going to want to take that same Revlimid pill if you're going out and you know it causes diarrhea. then you're not going to be taking it as often, and that might play into whether or not you lose your remission status. We want to keep you in remission, and the drugs don't work if you can't take it. The social consequences, this can affect your work relationships or your personal relationships. And then reduced efficacy kind of goes along with the adherence. If you're not taking a drug, it's not going to work. So effective management of the side effects are so important. Let's talk about one of the most important side effects that afflicts most of you that have been treated, and that's peripheral neuropathy. And I'm finishing my PhD, and one of the main focuses was a neuropathy study. Peripheral neuropathy occurs by damage to the peripheral nerve fibers. Now, they start in the spine, and they go out to your fingers and toes, so you might have numbness and tingling, or sometimes it's worse. It can actually attack the nerve endings and cause you pain. If it's bad enough, it goes into your muscles and prevents you from walking. So there's a lot of reason why you have to look for this side effect and make sure to tell your provider if you're having it. It won't compromise your treatment. Dr. Richardson and Dr. Dury and a lot of the doctors here have done research, and it shows that we can back off on a dose of medicine that's causing it, and you can still get benefit because we'll still be able to keep you on it, and I'll talk about that in a minute. The symptoms might be just numbness and tingling or some change in sensation, but it, like I said, can be worse. It can be painful, so report it immediately. So some of the things that you could do would be to massage the area with cocoa butter, keep stimulating blood flow to that area. Significant others, friends, family member can jump in and soak your feet in water and then massage it regularly once or twice a day. B vitamins. Now, this is anecdotal, but a lot of the B vitamins can help. Now, if you're B vitamin deficient, definitely we want to encourage you to take this. But some people also gain benefit from the amino acids in the B vitamins. And definitely, if you're not feeling your feet, be careful if you have trouble feeling your feet to not fall, or drive a car. Like if you can't feel the gas pedal underneath safely, just be very careful. If the symptoms worsen, we definitely need to have knowledge of that so we can adjust your doses so you get the myeloma control is balanced against the side effects. Another drug, this duloxetine, is an antidepressant, and the duloxetine was actually shown to reduce neuropathy symptoms. It was one of the first drugs. We also give this gabapentin and pregabalin. We have a lot of drugs out there, but this was the first one in a randomized study last year to show that it helped at 5 weeks. One of the most effective ways that we have to help neuropathy, if it's from Velcade or bortezomib, is by giving it subcutaneous. Subcutaneous is when you can get a shot under the skin. Intravenous is in the vein. There was a large study that looked at whether or not giving it this way was better or worse, and we found that it didn't matter. People actually did better when they got it in the subcutaneous route because they had a lot less peripheral neuropathy symptoms. And you can also back off to weekly instead of twice weekly, which is how the drug is often given. The approved sites are in the abdomen and the thigh, and it's recommended to just do a rotation so that you don't give it in the same place. Looking at other side effects such as myelosuppression, there was a question about low platelets before. We know platelets will go down, white cells will go down, and red cells will go down with treatment. And like Dr. Anderson said, sometimes it's from the cancer itself. We need to clean out the bone marrow to allow the healthy cells to grow. It's just like your garden and all of the weeds in your garden. Red blood cells, now this is your anemia number. The red blood cells transport oxygen, and if it's low, it's called anemia. And this is just so you get, again, familiar with the concepts. White blood cells fight infection, and if you have low white cells, it's called neutropenia. So somebody had mentioned their white blood cell count was 0.5, and a dose of the Revlimid needed to be adjusted, and that's very common. We know it can be from the drug or from the disease, so we want to make sure that disease is under control, and as long as it is, we would adjust the dose of the drug so it's not too much for your system. Platelets protect against bleeding and bruising, and you're either not making them, and that might be from the production plant, the bone marrow, or you might be having a destruction from the chemotherapy. Infection is really important to protect yourself against. Remember, multiple myeloma is a cancer of the immune cells. Their job is to tag foreign inviters and kill them, and unfortunately, the immune-producing cells don't work properly. Therefore, you're at risk for infection. The most common infections are in the sinus, respiratory, and ear tract. And it's worse in the winter months, at least with me in Cleveland, Ohio, where it was 1 degree this morning. We always get these kind of infections. So you really want to prevent it by washing your hands and, like I said, avoiding people with colds. We can give you shots to make your white cell count higher. But if it's temporary, sometimes we'll adjust your medications or hold it, and we really take into account the situation. Immunizations are so good. No live vaccines such as the single virus, so it's not recommended for people with myeloma or lymphomas and related disorders. But we do recommend pneumococcal vaccines and seasonal influenza vaccines. And actually, the Centers for Disease Control, they state specifically multiple myeloma patients should get 2 types of vaccines, the 13 one and then 23, and I can talk about that later if you want. Who's been on steroids before? Yeah, who's not? Yes, right. So we know there's a lot of bad effects of steroids, and I went and did some research with my Nurse Leadership Board members in 2008, and we, found that there wasn't a lot out there. As nobody talks about the side effects. They mention it in their little, but it's so old, a lot of people haven't mentioned it. But look at all of the side effects that the steroids can cause. A lot of the hyperactivity, you feel great when you're on them sometimes, revved up, you can paint the house, scrub the floors, and then 2 days later you're like, down, So those things need to be managed, and sometimes, and we know that now you don't have to take high doses. Was anybody on the doses that you had 4 days on, 4 days off, 4 days on? There's some nods in the room, and that was devastating. Oh, I couldn't imagine. But anyhow, now we have lower doses, and we're even going to teeny-weeny doses. Just because it marries so well with the drugs we're on, you have to have some form of steroids in your regimen usually. But we do have strategies such as sleeping pills if you're not sleeping, changing the dosing from AM to PM, and definitely taking, if it's affecting your stomach, take it with food. But if it's really affecting your stomach, there are some over-the-counter things such as Prevacid and Pepcid. Make sure you talk with your doctor before just taking it, but that might actually protect your stomach. Medications to prevent shingles and thrush might be recommended for you, and definitely it'll affect your immune system as well. So as I mentioned before, if you have a temperature of 100.5 or 100.4, depending on your doctor, report that, especially if with shaking chills. So the medications that we have out there, the ones that end in omide, thalidomide, lenalidomide, and pomalidomide, cause an increased risk for blood clots. Just from having cancer diagnosis of multiple myeloma, that increases your risk. So really, whether you're on those drugs or not, we got to look for the signs and symptoms of blood clots. VTE is what sometimes your doctor will call it, and it's 2 things. A deep vein thrombosis, which starts in an extremity, like your arm if you have a metaport in your arm, or the lower leg extremity, or PE, which can go to the lung, pulmonary embolism. Signs of a DVT would be swollen extremity, dull, achy feeling or tight feeling, discoloration to the skin. Definitely report this immediately to your provider. Usually you'll get swelling in one leg more than the other, or one arm more than the other. Pulmonary embolism is a life-threatening thing. That's when the clot in your extremity has shot up and catapulted to your circulation and can go into your lung, and that can be life-threatening. Shortness of breath, labored breathing, chest pain, anxiety, rapid heart rate, those are reasons to go to the emergency room. Don't leave a message on your doctor or nurse's voicemail, say, I think I'm having a heart attack, I can't breathe. Just go to the ER, and then let them know when you're there, and they'll help you out. So what can you do? And I'm sure you've heard this, and so I hate to be redundant, but just in case you haven't, all of you are at risk for it. I'm at risk for it, but because of your myeloma, you're at an increased risk. Wear anti-embolism stockings when you're traveling. There's some conflicting studies, but I say, gosh, if I'm at an increased risk and stockings that help my circulation might help me, it's probably something to consider. Those are those elastic stockings. Exercise, not going and running a triathlon or a marathon, just getting up and walking around and not sitting for too long. That's why when you're here this weekend, you'll have breaks factored in, and if you need to get up in between, then get up and walk around. Travel precautions, like if you're on an airplane or a long car ride, pump your legs, get up and move around, take breaks, go to the restroom. That's all important. And when you're taking those OMIDE drugs, the thalidomide, lenalidomide, or pomalidomide, those are the pills to treat your myeloma, the medications can be adjusted, such as if you're on steroids with it, higher doses of steroids. So, we can talk to your provider if you have any questions. You might need to be on blood thinners for short-term or long-term too. Now, I mentioned diarrhea a little bit earlier. That's another thing I'm focusing on for my PhD. There are a lot of people in my practice that have been on treatments for a long time, and then now they're developing this horrible diarrhea. And so really focusing in what can we do to help you manage that, and really what's the cause. There have been some biopsy studies that have shown that it's almost like a graft versus host disease, it looks like. And I actually put an abstract at our scientific meeting this winter to talk about our experiences. But anyhow, you can use laxative. Watch out for laxatives if you're having diarrhea. Sometimes the over-the-counter vitamins and herbals can cause diarrhea, so be careful of what you're on. I had a guy that was taking muscle supplements as he was exercising, and he was great remission, but had horrible diarrhea, and he brought in his bottles. He was on mega doses of magnesium, which causes diarrhea, especially in high doses. So just be aware of what you're taking. Increase your fluid intake if you have it. You're at risk for dehydration. That can shut off some fluid supply to the kidney, and that can cause damage to your kidney. So if you're having lots of diarrhea, we need to make sure that you're drinking adequate amounts of fluid. Avoid caffeinated or carbonated or heavily sugared beverages, because that can trigger the diarrhea as well. Antidiarrheal medications are okay, but your doctor, nurse, and provider needs to make sure you don't have a certain kind of bacteria. So if you've never had diarrhea before, then you get horrible diarrhea, then that might be an infection. So make sure to have that conversation, and they can recommend some treatment. So just make sure you talk to your provider. Pain management is really important, because if you're having pain, you're not going to want to get up and move around because your bones hurt. And then you're going to be at risk for blood clots and pneumonias because the air isn't moving in and out. So it's really important to control your pain, and don't be stoic about it. Try to have a real conversation with your doctor or nurse and say, this is what you're experiencing, when you're experiencing it, what's worked for you, what hasn't. There are medications. There's a lot of studies now with acupuncture. Sometimes you need a little mild surgical intervention. We've heard about kyphoplasty. So if you have a collapsed vertebrae, just by putting some cement in that collapsed vertebrae might heal that fracture if you have a fracture in your spine. And these are just some suggestions. There are a lot of complementary and alternative medicine supplements out there. I won't go into too many details now, but in general, have the conversation with your team as to what you're experiencing. Renal is another word for kidney. You can see this kidney bean here. This was from a publication we did a couple years ago with the Nurse Leadership Board. It's so important to protect your kidneys at diagnosis and throughout. The littlest thing, proteins are thick and sticky, and they might want to clog up your kidney tubes. How can you protect yourself against that? Well, anytime there's active myeloma or high calcium in your blood, you're at an increased risk. But in general, again, drinking adequate amounts of fluid, that's about 2 liters or 64 ounces of fluid a day, is really the best if you can get that. And preventing it by not taking the NSAIDs. Those are your ibuprofen, Motrin, naproxen. Those can be very toxic to the kidneys and turn off switch in the kidneys that protect against getting damaged. So try to avoid that. And as I mentioned here again, you want to drink, drink, drink. Now, if it's really bad, the kidney failure, that's your creatinine, that's the blood level, the creatinine goes up. That's the most important marker of your kidney function. You might need to come in the hospital for a little bit for hydration in the IV, and we might need to treat your myeloma maybe more aggressively, and sometimes dialysis. Now, the good thing about this, if there's a good thing about dialysis, is I can't tell you how many patients have come off of dialysis in the last 10 years or 15 years because of our newer drugs like thalidomide first and Velcade and Revlimid. We just are seeing a lot of dialysis independence because these drugs are so effective at controlling the myeloma, and we're getting people off dialysis, which is so exciting. In terms of health maintenance, we started with that piece of the puzzle put together and how important quality of life and quantity of life. But don't forget your health maintenance. What is that? Well, that's that going to the doctor, your primary care doctor every year for a physical, colon cancer screening, breast cancer screening if you're a lady, prostate cancer for a man, cholesterol checks. Those things can still hurt you. We can cure your, I don't want to use the word cure, we can treat your myeloma very effectively and keep you in remission for a long, long time, but then these other issues can crop up. What we know is that looking at everybody who's had myeloma diagnosis, it's called SEER, Surveillance and Epidemiology Results. They track everybody with cancers. The longer you live with myeloma, the more at risk you are for getting another cancer or other health condition. So anyhow, establish with a primary care provider, get your routine preventative screening, adopt a healthy lifestyle of eating well-rounded meals, and ensure proper care of the caregiver, because we want to make sure that if the wife is taking care of the husband, the wife is also taking care of herself, because that is really important. And if there's any changes in your health, skin cancers or anything going on, communicate with all members of the healthcare team. I've overstayed my welcome, so I'm going to stop here and say management of multiple myeloma is complex. I am so excited to see that all of you are taking time out of your busy lives with life going on to get more information about your health and how you can take care of yourself and your family members if you're a caregiver. You can optimize your quality of life by recognizing side effects. All these things I mentioned, look for them, the fevers, the diarrhea, the neuropathy. We can minimize those side effects to keep you on drug longer and have a better quality of life. Don't forget your health maintenance and ensuring proper care of the caregiver, because those are also important. I'd like to stop here and say thank you, and I'd be happy to answer any questions I can.
Can you prophylax against some of these symptoms, such as a probiotic for diarrhea? And are there any things you can take, such as black currant seed oil, to prophylax against peripheral neuropathy? And is low-intensity light therapy safe to use for myeloma patients for peripheral neuropathy?
Okay, I don't have a notepad to try to remember all these things, so I'm going to start with the diarrhea. Can you prophylax against that? So probiotics are something I routinely recommend if people have a history of irritable bowels and their bowels are, look at what kind of food you're taking. Something as simple as a food diary, writing down what you had for breakfast, lunch, and dinner. Did this cause diarrhea? Did it not? Trying to make that connection. Some people can eat lots and lots of fiber and don't have a problem, but somebody has a bowl of Chex cereal for breakfast and says, oh, I don't usually drink milk anymore. So lactose intolerance is something that can develop. So to answer your question, probiotics are fine, and yes, look at your eating habits and see if that correlates, because we can meet you with me or a nutritionist. The second one was peripheral neuropathy. Dr. Richardson, Dr. Anderson, and the group at Dana-Farber have recommended a regimen of B vitamins, amino acids, and pills to prevent the neuropathy. Research is lacking, and that's one of the things I did my PhD on. And unfortunately, we still don't have a good prevention. The best is prompt identification of symptoms, give the Velcade subcutaneously, and not in the vein. That makes a big difference, big decrease in neuropathy, and that can definitely help you. The last one was about low-intensity light therapy. Oh, low-intensity light therapy. I don't see any contraindication. I have a couple of my patients that experience that. So.
Some providers who use the laser told me that the photobiogenic treatments or results can stimulate cell growth, and they're concerned that it stimulates cell growth of cancer.
Yeah, I think that in my experience, I haven't shied away from that. I think in solid tumors, there's more literature. There's just not a lot known in myeloma. And if you're not comfortable, maybe we should table that and for another time or more evidence. Yes, I think I have to go by the little yellow things. So sorry.
Thank you. With the many varied treatment. With the many varied treatments and facilities and specialists involved in this confusing disease, how does a patient determine who to go to, where to go to, how far to travel, and where to get treatment that's best for him?
That's an excellent question, and I think that throughout this weekend you're going to hear some wonderful answers to that. What I tell my patients, you know, I'm at the Cleveland Clinic, we see thousands of myeloma patients, so we have a large center with lots of people that travel, but you have to look at cost and convenience and comfort. So cost of travel, convenience, how far is it away? Because if you're in a car for an hour and a half, 2 hours each way, twice a week, how's that going to play into your quality of life? And definitely a lot of the larger institutions go to for an opinion, but we work with local community physicians all the time. So they'll come and see us once or in 3 months or 6 months or yearly even. So you have that connection if something goes on. So I think the International Myeloma Foundation has a hotline you can always call and get information in your area of the specialists. And really the IMF is here to provide that resource for you. Where do you live? Do you live down here or? Clearwater, yeah. So there's a lot of groups down here too. So that's just what I tell people, whether it's right or not.
Well, since your PhD is on neuropathy, this is severe peripheral neuropathy. Dr. Ochoa at the Moffitt Center called it that in his feet. And is there any way that, I mean, he has exercises from a physical therapist that he does, you know, but is there any way for it to be regenerated? I guess nerves are a long time regenerating. And this was from Velcade. And Dr. Rafat Abenar at IU, our oncologist, hematologist at Columbus Regional, Indiana, called Dr. Abenar, and they got him off of Velcade after 3 cycles and put him on Kyprolis. Now, there's no more worsening neuropathy from Kyprolis, and Kyprolis is actually attacking the multiple myeloma. We know that.
That's great to hear.
So here you go. That's it.
Oh, that's okay. The nice thing about the Velcade-induced neuropathy is that we know that it will get better over time if we don't give any more offending agents. I've seen people that have had 2, 3, 5 years ago Velcade, horrible neuropathy. We can put them back on that drug if it worked subcutaneous and weekly. You know, that's just what we do. So it's not like he can never have that drug again. But if Kyprolis doesn't work for whatever reason, that's an option. But in terms of treating the peripheral neuropathy symptom, I do pain medicine. That duloxetine, that drug, Cymbalta, that didn't work.
Well, he doesn't have pain.
Okay, it's just numb.
No feeling.
Just no feeling. So that could get better over time. Continue the exercises. Rub his feet twice a day. I'm prescribing that. And I have a avid tennis player in my practice, and he didn't do any of what I told him, but he realized over time he was using his feet, and just that stimulation of the nerve endings, it took time to regenerate, but it did. So, thank you.
Okay, Joe,
I'm talking too long.
question in the back?
Yeah.
I've learned to make Dex my friend. I take it at night. I take it at 2 in the morning.
Good.
And I sleep beautifully.
Good.
And I've got a lot of energy the next day, and I get a lot done. So if you have trouble sleeping, I urge you, take it. Don't take it in the morning.
Take it at night.
Take it at night, because I don't think it starts working to 6 or 8 hours after you take it. So that's why I get a good night's sleep.
One meeting, we have somebody speaking.
Yeah, so in case you didn't hear, take Dex at night. And that was on my little slide, and some people swear by it, so thank you for sharing that testimonial.
Question right here, Beth.
Hi. What about turmeric? I've read things about it, but nobody ever discusses it. So.
Well, in the 1990s, turmeric was, I think Dr. Middleman in Israel had injected a tumor with the mice with the turmeric, and it killed plasmacytomas. And we thought, oh, this is going to be great. We have a new treatment for multiple myeloma. But then when they put it in humans, the concentration seems to be so high, and it's a seasoning like turmeric, curcumin. And so it makes your mustard yellow. So I tell people, put mustard on your hot dogs or your veggie hot dogs, but in high amounts it causes a lot of stomach distress. So we know anecdotally it might have some anti-cancer properties, but we don't have a good dose or good studies. 500 milligrams, I have one individual with smoldering myelomas taken it for years and swears that's how they haven't progressed. I think they were just lucky, but it's something, it shouldn't hurt you if you can tolerate it. Thanks.
Question here.
Is there such a thing as myeloma cell spots as a rash?
Well,
That's one
that's
question.
a great
The other
question.
question is. All right.
Yeah, the myeloma cell spots is a rash. I don't know of it. I don't know if Dr. Dury is in here. He's probably not. But I have seen, thousands of patients, and I've seen that it can affect the skin, but it mostly in tumors. Or the rash can be a side effect of the myeloma being active, but I don't know if the myeloma cells being rashy.
The other question is, if you're on maintenance, what would be the early renal or kidney symptoms and would that indicate stopping the maintenance?
It's a good question. It depends which maintenance you're on, if it's Revlimid or Velcade. And, Velcade's very happy with the kidneys, and sometimes with Revlimid, that's happy with the kidneys if you reduce the dose. So if you were diagnosed and that's how you knew you had myeloma, is because it attacked the kidneys, then we also look at the proteins in the blood, proteins in the urine. We look at the whole picture, not just the kidneys. So drink lots of water, get your regular blood work and your regular visits. It's not necessarily that the drugs itself are harming the kidneys, if that helps. No real symptoms.
I had two things. First of all, the idea of making Dex your friend is interesting. I'm the caregiver. I'm making a sign that says it's the Dex dummy because because there are changes in behavior that I have to keep in mind are not him. It's the Dex. What I've found is that he takes it at night before he goes to bed. That's fine. He sleeps that night. The next night, he wasn't sleeping very much at all. And he's now resorted to taking some, I don't remember what you're taking. It's an antihistamine. In the drugstore recommended using that instead of the higher price name brand sleeping medicine. It's the same drug. So that helps. But what we've also found is that he has neuropathy that causes pain. And sometimes it's very intense. The day after, let's say he takes the Dex on Tuesday, on Wednesday his pain is very much reduced. But on Thursday, it comes back with a vengeance. And we haven't found it. He had Velcade in 2008, and
That's
stopped it.
something you can hear from time to time. Is that you get, after transplant, after Dex, you can get a flare of that pain. Some of the things that we need to make sure, if you have neuropathy, that your provider has looked into: do you have uncontrolled diabetes? Alcoholism, and different, there's a lot of health conditions, vitamin deficiencies too. So make sure that that's all, thyroid looked into, and then if that's all looked into, he might be a good candidate for some of the nerve pills that are out there. Gabapentin, pregabalin, they were all listed in my presentation, and that Cymbalta or duloxetine, which was just shown in a study. This gabapentin has never been shown in trials to actually make a difference in other cancers with neuropathy, but it's never been tested in myeloma patients with neuropathy, and a lot of people do feel benefit. So pain medicines and the nerve medicines to tell your brain to not notice the pain.
One of the things we were told about the gabapentin was that it had an effect, or it could have an effect, on the kidneys.
No.
Which is, no?
No, not that I'm aware of.
Oh, okay.
I use gabapentin all the time. Cymbalta or duloxetine is one of the newer drugs that you have to be careful with kidney, but if his kidneys are in good functioning order, it should be okay.
Okay.
So, is anybody else? Yeah, okay.
Okay, Beth, thank you.
Oh, my pleasure. Thank you.
And before she goes, I just want to tell you how dedicated she is to coming to these seminars and making sure that all of you know how to overcome the side effects. Today is her son's 4th birthday. She's running to hop on a plane now to go home. So big round of applause for this mom
Thank
and
you.
wonderful, wonderful nurse.
Thank you.